7 साल इतने लंबे लदक गया था तो दादा बंद पर क्या कैमरा तो देखिए कैसे पेंटाटिक अच्छे निकले बाइक अच्छे निकाल
We are still using the old conventional pusher, cannula over pusher, pusher over cannula, not a single action.
or black tube.
Introducer के बाद फिर you have the stent and
Then
then
you have the pusher with the long wire, of course.
Introducer
cannula को black tube के ऊपर गया the ERCP cannula उसके ऊपर stand है उसके ऊपर पीछे से pusher.
So when you are pushing in the stent over the introducer, do you need to do the fluoro at that point in time? Because you are not able to exactly find out whether the pusher, I mean the introducer is moving or not.
Right. So I do use some fluoro. Dr. Saab के point था कि you don't need a lot of fluoro. You need to use stand of the fluoro. आपको अगर अंदाजा हो कि what the length of the stent is and how far it needs to go, तो intermittent fluoro के साथ आप कर सकते हैं.
Minimum use.
Do you have ERCP lists daily?
My setup I don't. I have 3 days of ERCP. इसमें फिर combine हो जाते हैं so 2 months के US ERCP combination and then 1 day of ERCP. 4 days break and
हाँ शहरिया कहाँ पहुँचे आप? अरे शेरेटन नहीं मैरियट
इसको पीछे आ गया
शेरेटन की गली में आगे है तो आप पहुँच जाए मैरियट में एंड रेस्ट में खाली तो लोग आ रहे हैं बाकी no but I don't know
fourth one is it?
fourth one is done. Please ask any questions you want to. This is your chance. On humans, I'm not going to answer any. This should almost be there, so if you can come down.
नहीं वो थोड़ा सा कर लेंगे बस थोड़ा सा पुश कर लेंगे.
वो लोग शेरिया और लोग ऐसे.
अच्छा अब आप थोड़ा सा अगर पुल कर लेना स्कोप को साथ में ठीक है. स्कोप पुल कर लेंगे.
कोई है गाड़ी.
White Toyota होगी
चलती है.
सिटी होगी दोनों की बता देना.
Okay, so
Then your trans abdominal assist is needed. Before consideration.
अच्छी पोजीशन में दिया था तुमको. तुम लोग पोजीशन खराब करते हो. Okay, good. Whatever you did was good. Big wheel up. Big wheel up. थोड़ा सा pull back. Just a little bit. अब नहीं बहुत ज़्यादा हो रहा है. अब थोड़ा advance करें. थोड़ा lubrication से ज़्यादा it's done its job. I don't want to waste too much time. चलें. बहुत ज़्यादा टाइट हो गया है. These dummies are very expensive. We don't realize the colon is 5,000 pounds. 5,000. But that's actually a little better than this. This one is not so good, but it does it does the purpose. Though. I think we are almost there. I'll just help you with this a little bit and I think okay. Excellent position.
Sir, making a point of reference.
Sometimes I turn E1 and I go under vision.
most recent case.
Most.
Some parts.
Dr. Saad, making a point of reference, मतलब when we hold the wire at a point of reference, does that help? Does that have an advantage?
What do you mean by?
What we do is, for example, we know that we pushed in the guide wire, looped it over, and while we're pushing in the stent or we're pushing in the introducer for that matter, at times we ask someone to hold that wire so that that wire is at a point of reference.
Okay, you've got a reference point in terms of the distance
The
away.
distance, yeah.
I think you do that. You can do that. I mean, we do that for dilatation, esophageal dilatation. But for this, because you have the excess with fluoro, and you also have the newer wires all have some kind of marking, so you can do that. All that. Whatever is, as long as you know that your wire is not moving out, that's important. क्या वायर अंदर डाले डॉक्टर साहब और हाँ ठीक है कुछ CBD wire अंदर डाले because you need to be deep. Wire advance the wire please.
Yes.
Pull the cannula back. अब आपका देखिए वहाँ पे see what you need to do is wire वो tight तो करेगा आपका distance थोड़ा सा वो हो गया. So in normal circumstances you would use the big wheel and bring it closer to you. Okay. So now you maintain that position. This position should not. अब ये जब हो रही तो use the big wheel again a little bit. देखिए अभी आपका function कर रहा है. Okay. Right. I think it's long enough. Now what do you want? Stop. अब बताएं next क्या step है? You're going to take it out. So you tell him. मैं अपनी कैनरा निकाल रहा हूँ. Wire exchange भी कह सकते हैं आप. All good techs would understand wire exchange, which means that, and you can keep your eye on that. Now this orange is for me, the reference point. So I will keep my eye on that orange. तो orange ऊपर आएगा तो वैसे कहूँगा अंदर डाल दो, अगर वहीं रहेगा तो that's fine, and it's keeping its position. So elevator से wire को block करना या hold करना is obviously much more important when you're pulling something out. Then when you're going in, don't really. Sometimes I do. Sometimes
We tend to avoid doing that because that scratches the wire.
especially if you no, you couldn't. Remember, your wire is not supposed to come out. You're only positioning it there. So if you've got a good wire exchange, wire position remains same. It's the same.
Sometimes gets a kink or something with the.
Yeah, but that's because you're actually pulling
Holding
it up.
it too.
No, you're holding it tight.
Maybe we're just
हमें
holding it
इतना
too
मसला
tight.
नहीं होता. We don't have that problem because it will not. You know, you're holding it actually is facilitating, but it's facilitating him. That is only happening when actually the coordination between you two is not there. That may be the reason. We do it all the time. Wire doesn't. Good. So आपने इनसे बात की, मुझे आवाज नहीं आई. आपको कुछ बोला था इन्होंने? हाँ? तो फिर आपने क्योंकि आप खबरदार तुमने कोई चीज की. कर क्या रहे हैं आप?
एडवांस कर रहे हैं सर.
किसको?
कैसे
और टेक्नीशियन कौन है, मैं या अकरम?
अकरम भाई कैसे एडवांस कर रहे हैं?
Right, sir.
अकरम भाई से दोस्ती नहीं की आपने सही तरह से, तो वो आप कुछ नहीं करते रहे, उसने से मेरी चर्चा दे दिया तो काम हो गया. So I mean you've got your elevator up, so you're holding the wire, you're going in, but everything you're doing is fine except that Akram is doing it, you're not. ERCP जब इतनी खामोशी से होना तो there is a problem. Okay, what is he supposed to do now? Stop.
वायर पुट करें.
Wire pull करें. Guiding catheter is going in.
Yes.
Wire is being pulled
Yes.
out. Good.
Yes. Yes.
और आप अपने एलिवेटर से इसको ऊपर नीचे कर रहे हैं. इसमें एलिवेटर का इतना इशू नहीं होगा. This is a 6 French catheter which is okay. It's a stent which becomes 10 French and the pressure on elevator becomes more. With the 7 French stent there is not much of a problem because the therapeutic scope elevator पे इतना pressure नहीं. Okay. ठीक है, good. See, you have 3 markers on this one. I don't know whichever one you use. This is telling you this is almost I think 5 or 6 centimeters between these two, and then the same. So if you've got 3, you know that you're at 10. So that's another way you can calculate. We will also touch on how do you calculate the length of the stent.
Yes.
अब आपका position है, एक minute, this is dangerous. what has happened is you've lost the position जो आपकी करीब थी. Well done, well done, well done, well done, well done. Excellent. आपने क्या किया अभी?
Drill down किया.
Well done. Now एक मिनट. जब आप what is happening एक दफ़ा आपने कर लिया, अब आपको अंदाजा हो गया. अब आप अपनी पोजीशन को उसी जगह रखेंगे जब आप एडवांस करेंगे. तो you have to communicate with him. What happens is आप एडवांस कर रहे हो, ठीक है, वो पुल बैक नहीं कर रहा. तो पुल बैक नहीं कर रहा तो एक्चुअली ये असेंबली और पुश हो रही है. अब आपकी इट्स नॉट जस्ट वायर, इट्स गाइडिंग कैथेटर, सो इट्स एक्चुअली पुशिंग इट अवे. सो नाउ डू दैट. चलो.
Yes, full
एंड एलिवेटर छोड़ा हुआ है.
रिलीज करना पड़ेगा.
एक्सीलेंट, दैट्स अ गुड पोजीशन. आपने रिलीज करवा दिया, रिलीज हो गया.
Release नहीं.
तो फिर रिलीज नहीं हुआ तो स्टैंड कैसे निकलेगा? क्योंकि वो पुशिंग गाइड. ओके, गुड. कीप दैट पोजीशन. एक्सीलेंट, ठीक है. आई थिंक दैट शुड बी फाइन. नाउ ही नीड्स टू पुल बैक.
Release.
तो आप उनको कहेंगे आप पुल बैक करें, मैं अंदर जाऊँगा. देखिए आप सिर्फ आपके पुल बैक, उसके पुल बैक करने से कैनुला और एम्पुला करीब आ गया. Do again the same thing. I would like it again coming close to me. वो आपको वैसे ही अंदर चला जाएगा क्योंकि ये यहाँ पे फंसता है, वो वहीं पे फंसा हुआ है. It's literally like a stricture there. So it gets stuck as it's coming out of that little tube. So it's really behaving like a not very tight but a stricture.
Yes, full
Right. अब आपका डिस्टेंस हो रहा है. गुड. यू जस्ट गॉन थ्रू इट. वेल डन. वही चीज करें मैन्यूवर जिससे आपने पहले किया था. एक्सीलेंट. गुड 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 गुड. I would keep now if this position is very good then I would just keep the hands like this. Now you can see what's happening.
Yes, full
Pull back.
Yes, full
शरियात से पूछ ले. मिल गए? मिल गए?
मैंने उससे कहा कि डॉक्टर
तो फिर तो खालिद नजर ही नहीं आएंगे.
हाँ, तो वो कहते हैं डॉक्टर बकार का नंबर, तो मैंने उनको कॉल करके कह रहा है वो कहाँ पहुँचे. मैंने कहा डॉक्टर बकार वार्ड में आप, तो फिर खालिद को कहा.
फिर डॉक्टर वकार को देख रहा था, खालिद नजर नहीं आएंगे. Okay, good. See, again, time and again I've told you, if you're guiding catheter, make sure that it's not come back. And that's where fluoro comes. To spot fluoro, you know it's this black tube which is guiding catheter is deep in. ये अगर बाहर आ जाएगा, यहाँ आ जाएगा तो स्टेंट पे मूव नहीं करेगा. ठीक है? चलें. चलें, आगे. Good. You're almost there. Well done. और ये जो पीस है इसको आप करेंगे तो आपका सेंटर में रहेगा. अब आपको थोड़ा सा उसको पुल बैक करवाना पड़ेगा.
Yes, full
ठीक है, पुल बैक. That's good enough. I'm pretty happy with that. You can see the flank. So now release. एक मिनट है. We get. अब आप उसको क्या कहेंगे? आप लोग क्या कहते हैं? Normally क्या कहते हैं आपके बॉसेस? आप
Release.
रिलीज. रिलीज में आप क्या करते हैं?
Hold करेंगे.
ठीक है, good. So you hold the pusher, and a good tech will also hold the pusher and just pull back the pusher. Good.
flash
वो पॉइंट मुझे याद आया था, मैं एकदम भूल गया था.
Second part of the duration at the time of intubation. क्या techniques या कितना हमने advance होके भी इसको reduce.
Sometimes you can actually go in, literally bulb से आप निकले first part D2 सिर्फ नजर ही आया and you can pull back and you go in. Sometimes when you try and pull back, you actually come back to the stomach. In which case you need to go a little deeper. Otherwise, for most patients, you really don't need to go anywhere beyond just getting past D1. And that you can do by rotating, locking, it will. we'll show that for you. This is, but it's a very standard unit. With experience, sometimes then a lot of patients you really don't need to do anything. You just need to do a good rotation and you're actually. But what is important is that jerky and rapid movements to avoid. In ERCP, when you're doing your cases, you need to learn to be still. So when you're doing whatever you're doing, your scope is, in difficult cases, is literally here. It's like, for me, it's here. And then you can make me do whatever I want. Okay, but scope position has to be still. Especially जहाँ पे कभी मुश्किल भी हो तो you just don't want to do it. There's a practice, I think, once I've gotten, I like to have my position, I don't like it. And at least if you're moving, I'm talking to you, I know that to bring it back here, I need to talk to him, so I talk to him, position you well. How do you determine the size of stent that you're going to use? What do you do in your practice?
So it's a problem really, they say that 10 into 10 it's sufficient for the, it depends on the whether it's stricture or the lesion or the problem is in the distal. Then we use.
So it depends on the site of the
site of the structure.
Fine. So supposing you have a distal CBD stricture, and general rule of thumb that we use is that if you have a distal CBD stricture, a pancreatic mass or a pharyngeo or an ampullary, if you have an ampullary, a 5 centimeter stent is going to be more than enough. But we generally don't use 5. So we have 7, 10, 12, 15. Those are the sizes we have. So for anything that's distal, 7 should be enough. For mid CBD and anything above 10, 9 or 10, 10 should be enough. Going above the hilar area, then you have to see how much deep you have to go there. 12, 15. So 15 is बहुत ही rare होता है. I use 15 for living donor liver transplant. Because उसमें you need to have that extra length. जरूरत तो 10-12 में भी हो जाती है, but when you are advancing the scope, stent, there is a very difficult. Sometimes there's a looping that comes when you're placing the stent, and that requires those 2-3 centimeters extra. Because once the stent is actually past that stricture and straightens and usually goes much deeper than what you generally would like, but then when you're advancing, sometimes you'll get caught with 10-12. So if it's a difficult stricture and very sharp, then I would, and if the distal CBD has got that little kink which gives you a big seat when you're putting a wire, a guiding catheter or a stent. So I think that's something that I've learned. But that's the general rule that we have. Can you measure the stent exactly centimeter to centimeter? How do you do that?
For exact measurements, what we used to do in Sheikh there, we used to take the tip of the tip beyond the structure, and then pull it back till it came out, and we used to measure this distance which
you understand? So you've gone in with a wire and guiding catheter or cannula or whatever you have. If your wire is in, your cannula is in. You have both the options. You can take the catheter out. This is where your scope is. This is your duodenum, right? So your scope is like this. You're looking at the ampulla here. यहाँ पे आपको पता चल गया, this is your stricture and this is where you want the stent to be. So you take your wire is up deep. Take your catheter to this point. Usually the tips of all catheters have some kind of a marker or something that's radiopaque. So you take that, and in one stride, from this end, you start pulling it without anything. And on fluoro, you can actually see it coming down, or on endoscopy, you see it come down literally when the wire becomes visible, and you're almost close to the end of your scope. That's when you stop. So what you do is that end, which is this side, you then have, let's say, this pitch of catheter. Catheter जब आपका आ गया, so you measure that, and you can actually have millimeters if you want. Do you do that? I do that. Vakar, do you measure your with the wire or catheter? I don't. I don't. I think it's a good practice if you do, especially at this stage. But if you use the 10-7, 10-10, 10-12 thing, the way we explained, in almost all cases you will probably be okay. But in your early stages, I think it's sensible to measure. It only takes a minute to measure. You have the option of, as I said, either taking the catheter or taking the wire. Whichever you
But the measurement you mean to say is how much below from the lesion you need to measure, or do you need to measure the length?
Where do you want the tip of your stent to be?
Top.
And how much is the stent? Like this was what, 10-7 thing?
10 sir.
10-10.
Yes sir.
So the measurement of stents, you must remember, is between the flange. When it says 10-10, it's not this length. It's the length between the flange. This is what they are saying is 10 centimeters. Okay, French आपके पास options जो होते हैं हमारे पास, they have a lot more options, but we have 5. I mean, I have 4-3 as well, but generally speaking, 5 French, 7 French, 10. There is an 8.5 and there is a 11.5, but 11.5 wouldn't go through most scopes, so it's a waste. And if there is no evidence that I've seen anywhere where it's more advantageous to put an 11.5 versus a 10. So for all practical purposes, 10 French is the size you want when you want drainage. For 7 French, I use them in living donor liver transplant when I'm doing first time. So first ERCP when we do with a stricture, we put a 7 French, and we bring them back after a few weeks, whatever, 6 weeks, 12 weeks, depending on how well they are, and try and put 2 10 French. For pancreatic duct, it depends on how much dilated pancreatic duct is. For prophylaxis, we use a 5-5. 5-3 would be even better. For pancreatic duct की therapeutic drainage के लिए, it again depends on the size of the duct. So if a duct is very dilated, then you can use a 10 French as well. First time, I don't try and go beyond 7. Patients do have pain after pancreatic. So we go in with 7 French and then I call them back. Usually, pancreatic stents, interestingly, don't get blocked that often, unlike the CBD. So stent in pancreatic site with 7 French will last a year, year and a half. Patients fine, so they don't even bother coming back here. And then next time जब मैं बुलाता हूँ, then I go in with 10, or sometimes I put multiple. I prefer putting 3 stents. So if I instead of putting 2 7 Frenches, I would prefer putting 3 5 French. It gives a more circular kind of expansion. Same with 7 French instead of 2 10 French. Maximum I put in pancreatic duct is 5 stents. 7 very direct, but that's the maximum I've done. CBD, I don't go beyond 5 stents for strictures. Because I don't think personally there is nothing that I've read. I've heard people put 7 also, but I don't think ऐसा किसी ने show किया होगा कि 7 is better than 5. I don't know. I don't even know whether 5 is better than 3, but 3 पे वापस निकाला है and they've strictured again. So then I go put 5. Single pigtail is very useful for pancreatic stent. It avoids internal migration. That's why you have that pigtail. You don't care it coming out, but you don't want it going in. So prophylactic stent should be ideally single pigtail. For CBD, otherwise, do I put 7 French stents? Maybe for stones, you can put a double pigtail stent. 7 French, I'm more comfortable. 10 French double pigtail, I only use for pseudocystis. Do you want to add anything?
Yeah,
Double pigtail stents are also being used for CBD.
We use them in CBD.
7
Sometimes
7
when-
French, not 10 French.
10 French.
No, we don't.
When we have, I told you that we have an excessive use of precuts, so in order to hold the stent inside, we have to put in the pigtail stent. They tend to fall off.
Because they tend to fall off for what reason? You're putting them in stricture or you're putting them in stone?
No, in strictures, more likely.
Strictures they shouldn't fall. If you put a stent properly, very small percentage actually come out if it's a tight enough stricture. And for my worry is with double pigtail 10 French stent in the CBD, the other pigtail that's inside, that worries me.
You have to have a very large size.
You have to have a very large
We actually
pigtail
want
CBD
that,
for.
inside it.
Let's
No,
say-
we have to, not in every CBD, but we tend to, when we have a dilated CBD, we prefer having the double pigtail inside because
That's
we
what
have,
I'm saying, that our practice is 7 French,
because
not 10
we have,
French.
I know we have actually problems with the pushers. We do not have pushers for 7 French. We only
You don't need pushers for 7 French. I use the 6 French guiding catheter, yeah.
to do that.
Yeah, you don't need a pusher. 7 French is so you can use anything that's 6 French.
Open the balloon, close the balloon.
Yeah, you can use a balloon, yeah, you can use
Whatever
anything.
device you have.
But Dr. Saab, my worry is that both of us, and I'm sure Waqas, we don't put 10 French double pigtail stents inside the CBD. I'm not happy. Unless it's almost a polydouble system. You know, with a huge, with a big stone underneath it and whatever, so that maybe, or if there's a history that stone may migrate. Stricture migration occurs, I'm not saying it doesn't, but it's, for that, putting a double pigtail stent worries me, especially high up.
इसमें बनवाते तो straight stents usually tend to go together.
Multiple straight strength.
If you worry about migration.
And by the way, this notion that needle knife would actually allow stent to migrate is actually not, because when you've done needle knife, you've done sphincterotomy. Assalamu alaikum. I have. Seven French इसमें मिला था.
मेहमान पहले पहुंच गए
वैसे मैं सच्ची बात बताऊं जनाब कि पहली दफा मैंने आपका बहुत शिद्दत से इंतजार किया.
अच्छा सलाम अलैकुम चलिए जारी रखें
So we are
मैं तो
almost.
अभी सोया हुआ हूँ
I know, you go to sleep. मुझे एक केस, वो एक केस जो हम लोग 2-3 दफा से नहीं कर पाए ना, जिसका वो डिफिकल्ट डायबिटिकुलम वाला, वो पहला था, वो खालिद साहब ने करना है. ऐसा एक केस मैंने कहा पहला केस वो वाला रखिएगा, मैं 3 दफा कोशिश कर चुका नहीं हो रहा, एम्पिल ही नहीं मिलता.
ढूंढेंगे है तो सही लगेगा नहीं तो बना
नहीं, इन लोगों ने निकाल दिया है यार. आप कॉफी पियोगे चाय?
हाँ मैं
No, but what do you want?
anything is
So you will come, you just sit down or so length. I would agree with him. That's the better way to do is to measure and do. They have
आपका point is very valid. If you're unsure, तब आप ये करें कि an easy way is to measure it so that you don't.
Fall
get
short.
the
wrong
last
side,
thing you want to
don't
do is
start
put
over.
and especially if it's a difficult case.
Difficult case. कि आप
Don't,
डालने वाला
and to be on the safe side, longer stents not going to harm you. Stents is the same price. And putting a 10-10, 10-7 is only 2 centimeters more effort. Or 10-12. Long stent is not going to harm you. Short stent will make life difficult. So at least if you're going to use, I think it's a very good practice in your case to go back and measure. Honestly, it's a good
We
practice.
measure and take it as the lesser point, like we are getting 6 on the side, then we prefer a larger stent.
Has to be,
Yeah, if you're measuring 6,
Yeah.
then you know a 10-7 is almost a 9 centimeter stent. Okay? So you have to remember that this stent is longer than 10-10. Okay? Because इसमें ये count नहीं हुए दोनों ends. So अगर इन दोनों ends को मिला लो तो about 2.5 odd centimeters बन जाता है. So that's what you need to add. So अगर आपकी length 6 आ रही है, आप 10-9 का stent अगर डाल रहे हो तो it can't be short. It's already about a few centimeters away. And because you're measuring so accurately, then you can play with it a little bit. Sometimes, when you are putting the stent, how does it migrate inside? You are actually early days. You are not communicating, and जब आप last bit आपका stent आया तो something moved, and you panic, and in that panic you did not communicate. He pulled the guide wire. He kept on pulling the guide wire in. the stent actually went in, more than it should have. Do whatever you have to immediately. You can move the stent out very easily. If you've got access with the wire, no issue. Don't lose the wire. You can put the guiding catheter gradually again in, and as you pull the whole system with the guiding catheter, you'll be able to bring it out. If not, you have a little tip, you can take a grasping force and pull it out gently. We haven't spoken about metallic stenting here. Once you've placed it, please don't try and move it. The moment you try and move it in or out, biliary, no, rupture is not an issue with the brain. It will migrate. It comes like a spring. So अब थोड़ा सा हो गया जैसा हो गया, you have to put another one or do whatever you do that, but I personally feel that I can agree with that.
Anjali, you're talking about covered metal or uncovered?
Covered,
Uncovered, so it's pretty much there. You
not gonna
will
be.
only mess it up, but it's the shape probably if you start putting on it. Uncovered could be, covered ka ye aap sahi keh rahe hain. Once if it's too far out, you can't push it in. And if it's slightly too far in, you need fine control.
Very fine control.
उसमें होता है कि if you grab something and you pull on it, then you jerk it. कई दफा आप ये कह सकते हैं you grab it and you just do back away with your big wheel. उससे थोड़ा सा निकल आता है, but that's a fine movement. Early stages पे I would not.
I think it's
encourage that.
my
Yes.
advice is
Just leave it
ask
wherever.
somebody else to come and spell it out.
हाँ.
और no harm. अगर आपको परेशानी है, put another wire, put another plastic
Plastic
stent.
stent.
Patient is safe.
Exactly.
Because no matter what you do, end of the day it's your patients. You are there not to have a successful procedure, successful cannulation. That's not what we do procedures for. We do procedures because we want our patients to get better. So end of the day, वो holistic picture ये है कि आपने जो भी किया आपने harm तो नहीं किया. And if you haven't harmed, look at how you can benefit your patient and do it. That's why I think it's become, we've come a long way. When I used to be in Bhopal, we started our training, dye injection, pancreatic duct injection. I was told by none other than Adrian Hatfield, this is 1993, that I asked him, it's just generally, जैसे आप लोग आए, why do you inject, why do you need pancreatogram when we are looking at CBD? He says, what does ERCP stand for? It's a bada rude American English term. I'm sorry, but I never liked that word. I should. Do you see a pancreatogram P there? So you have to do it. Why the hell do you have to do that? You don't need the pancreas. Why you don't need it? And now we've come, none of us do that. In fact, you try your best not to do anything with the pancreas when you know you only need CBD. So this is evolution होता है ना, चीज आज जो हम कर रहे हैं 10 साल में और हम evolve करेंगे चीजें बेहतर हो. So keep thinking. That's the only way you get better. Don't lose your passion. If you're not passionate, please don't do it. I don't know about others. 4th day of my holiday, I need to go back to my endoscopy. 4 days बाद, my family is not happy. They want me to go somewhere because they know that I am really missing my hand. I need to have my hands. कुछ नहीं होगा. I'll find out कौन है यहाँ पे consultant. I'll go sit down, gupshup. I'll say I want to come and see your procedure. Oh, endoscopy करोगा, कुछ भी करोगा. I'll just keep doing the gupshup. But that's the kind of craziness I have for endoscopy. So there's nothing more in my life in terms of doing. I'm totally addicted. So you have to, if you really want to, be something. I used to sit down, जैसे आपका कोर्स है, हमने भी बताने भी, I'm sure डॉक्टर साहब ने भी किया, आपने मार्टिन फ्रीमैन and so many other big names. I used to sit on that chair and say, can't be like that. Then I said, why can't? You need to try. Whether you reach or not, Allah जानता है, Allah ताला की मदद आती है. आप अपना honestly काम करें. That's it. So we are now done for lunch.
Yeah.
And half an hour.
Half an hour, yes.
So we have covered just briefly. We've just told you about Intubation, we've talked about passing the stomach, 6 o'clock pylorus into the duodenum, maneuvers to get there, positioning the ampulla, bringing ampulla close to you, using different maneuvers to get it, wire guiding technique, if you want to use it, out, and we've shown you how do you wire exchange for whatever you want to do. We haven't touched sphincterotomy because unfortunately we can't do it on the dummy, but obviously in the next 20 cases you will see sphincterotomies in all of them almost. In between, we try and touch sedation a little bit. Antibiotic. I use antibiotic in every case. Every patient is now given antibiotics in our and I use them 5 days, even if I have drained the system. That's not scientific. That's not based on any studies that we have done. That's just our experience. I've shared this before with others. First time I came from UK, diagnostic, if we didn't do any therapy and good drainage, we never did anything. 4 out of first 4 cases I did here, 2 had cholangitis. I called my guys, I said, I've never seen this, what's happening? He says, are you giving antibiotics? I said, no, we never gave antibiotics. This is, I'm talking about 96. And he says, are you kidding me? You have to use antibiotics here. So there is a difference in the way we clean the scope, there's a difference in the scopes. We have so many factors, and so in our practice we use antibiotics. Even though I've drained the system, I use it. Now, I'm not saying that's correct, but that's my practice. I don't know whether I'll antibiotics
Selectively give it.
The biggest problem is the elevator and the buttons nowadays. So they harbor the bacteria. So now we are going to the disposable buttons.
Maria Morgan.
So that's where the bacteria harbors. And so I think you guys do the right thing by giving it.
Yeah, because you see, the thing is, we saw it was so often. In fact, I met your guy, the man who gave you golden gloves or what? Peter Gordon. Yeah.
Yes.
I met Peter Gordon and I was in Egypt workshop. So I was talking to him and I said, he said, why would you use antibiotics? I said, because I said, no, I don't think you should. I said, well, we're suffering. I don't think you should. And I don't agree with him. And he needs to come here, work, and show me that there would be no infection, and I will accept it. But at this moment in time, in our practice, that's what my recommendation in Pakistan. And I don't think most centers here would have the kind of cleaning with equipment that we have. Even then, I think, like you said, elevator, I mean, there's been a problem in US.
Yeah, there was a big problem with the infection, and that was traced back to the elevators.
There was a warning that was issued on Columbus website.
All my patients now,
We don't use antibiotics routinely.
We don't use routinely, but the issue is
every case
But
that we
in
do,
the US, we have the detachable caps now.
no, we don't.
Yeah.
We
Because
don't
in
use.
UK, we have detachable caps. So
for benefits or that.
what is it, for 6? So you have to actually clean, take them out for cleaning. Because most of the bacteria used to be harbored by through
There was a
brain
joint.
channel.
There was a joint between the cap and that.
But even in
I saw the warning.
brain channel as well. Because in 1992, I think, from the Radioactive, we published a series of 6 or 7 cases which had Pseudomonas, they called Pseudomonas septicemia infection when ERCP. And when we stripped down our scopes and everything, the microbiologists were very helpful in that. They found that the infection was only in the bridge channel. Because with the bridge, there's a channel which goes up if you normally don't notice. And then again, there's problem with the cap.
Then another thing that we have, Vakar, to add on to that,
Yes.
is that we reuse excessive drugs.
Yeah.
Okay, so we just hide.
Exactly, I mean, that again
Side
makes a big
so
difference.
cannulas are actually cavities,
Yes.
and we side them and everything, but I don't. The other problem I have now over the last 3 years I've seen is we're getting very serious resistant bacteria sometimes. So that's also
Still
one-
using Cyrex?
we use this.
You haven't shifted to parasitic acid?
We use Cyrex. And one of the problems, which is obviously not for the court, that's something that I've seen I get more infections with metallic stent than I have with plastic. Have you hit with a, I don't know. Huh? No, covered, partially covered.
Governments will cause
Partially covered.
pathogenesis. They definitely could be.
Partially, yes, covered. And so that's been another
But
problem.
the evidence is
And the
not
other,
available.
and the other, going to make evidence, that's not very, and the other thing that we have noticed is that our resistance in our E. coli that we get, leave the Pseudomonas for a minute. E. coli with ciproxin and other sphalosporins is pretty high. So I use, all my patients here would get 1 gram of merin pre-procedure. And then after that we go on oral antibiotics. If you drain the system and there's nothing else, then we just go on oral Cipro or Cefspran. But 1 shot we always do.
We give cefoperazone some Bactam
Yeah, but,
to begin with.
okay, so that's 1 shot that we give and then they go on oral. But some patients would now go on IV. All patients that are post-transplant, as I've learned from my Indian colleagues, they all go on IV antibiotics for at least 3 days. And they're all stay in house. If they don't have facility to get antibiotics, if they have facility to get their antibiotics, then they'll go to the place
So
over
wherever
there.
you understand the hashtag, I'm very sure.
Yes. So we're talking about anti-AIDS. We don't have cadaveric at all.
Yeah, there's.
For cadaveric, I'm not worried. For smaller, yeah,
Yeah,
because
because
smaller
like
say,
anastomosis is totally different.
guys have lunch.